Welcome to this video guide on migraine and headache, presented by the Department of Neurology and Psychiatry. We aim to help you understand the science, symptoms, and potential solutions for these conditions. In this video, we will explore the differences between ordinary headaches and migraines, discuss the biology behind head pain, learn how to spot red flags, review common primary headache disorders, and cover evidence-based management strategies. A headache is pain felt anywhere in the head, scalp, or neck. As a universal human experience, it is one of the most common reasons people see a doctor. Headaches can be primary, the disorder itself, or secondary, acting as a symptom of another condition. Headache disorders are incredibly common, with half of all adults reporting a headache in the past year. Migraine affects 1 in 7 people globally and is a leading cause of disability. Despite their impact, many of these disorders remain under-recognized and undertreated. It is important to note that brain tissue itself has no pain receptors. Instead, head pain comes from sensitive structures like blood vessels, the meninges, muscles in the scalp and neck, and cranial nerves, particularly the trigeminal nerve, which carries pain signals to the brain. Headaches are classified as primary or secondary. Primary headaches, like migraines or tension type, are disorders in their own right and make up over 90% of cases. Secondary headaches are symptoms of underlying issues like injury or infection and require addressing the root cause. Primary headache disorders include tension-type headaches, which are the most common, migraines, which are the most disabling, and rare but intense conditions like cluster headaches, along with other specialized forms of headache. Secondary headache disorders stem from other conditions. These can include medication overuse, trauma, vascular disorders like stroke, infections like meningitis, or issues related to brain pressure and mass lesions. To identify potentially dangerous headaches, remember the mnemonic SNOOP4: systemic symptoms, neurologic signs, onset that is sudden, older age at first onset, and pattern changes or other specific risk factors like pregnancy. The most common primary headache is the tension-type headache. It affects up to 70% of people in their lifetime. It is typically described as a mild to moderate band-like pressure that usually does not prevent someone from continuing their daily activities. Tension-type headaches typically feature bilateral pain, feeling like a tight band around the head. They are generally mild to moderate in intensity, are not worsened by routine physical activity, and do not cause significant nausea. The underlying cause of tension-type headaches involves increased sensitivity in pain pathways. Muscle tenderness in the head and neck is common, and stress can further increase muscle contraction. While peripheral muscle factors dominate in episodic cases, central sensitization is more common in chronic cases. Common triggers for tension-type headaches can be remembered as SPED, stress and anxiety, poor posture from screen work, eye strain and fatigue, and dehydration or skipped meals. Management for tension-type headaches involves acute relief, such as over-the-counter pain relievers, rest, and stretching. Prevention strategies include regular exercise, managing stress, staying hydrated, getting adequate sleep, and avoiding the overuse of pain medication. A migraine is far more than just a bad headache. It is a neurological disease causing recurrent, disabling attacks. It often presents as one-sided, throbbing pain accompanied by nausea and light sensitivity, lasting anywhere from 4 to 72 hours if left untreated. Migraines impact roughly 12% of the general population. It affects women 3 times more often than men, with the peak age range for attacks occurring between 18 and 44. The condition often begins in adolescence, is strongly linked to family history, and is influenced by hormonal factors. A complete migraine attack consists of 4 potential phases: the prodrome, occurring hours or days before the headache, the aura, the main painful headache phase, and the postdrome, which is the recovery period often referred to as a migraine hangover. The first phase, the prodrome, acts as a set of warning signs. Individuals may experience mood changes like irritability or euphoria, food cravings, often for sweets, neck stiffness, frequent yawning, fatigue, difficulty concentrating, or changes in fluid balance. The second phase is the aura, which occurs in about 1 in 4 people. These are temporary, reversible neurological symptoms that usually develop gradually over 5 to 20 minutes and typically last less than an hour. They are caused by a wave of altered activity across the brain. Auras can take several forms. Visual aura is most common, presenting as flashes or blind spots. Sensory aura involves tingling or numbness, while speech or language aura causes difficulty finding words. A rare form, motor aura, involves muscle weakness on one side of the body. The third phase is the headache itself. The pain is typically one-sided, throbbing, and moderate to severe in intensity. It is often worsened by movement and accompanied by nausea, vomiting, or sensitivity to light and sound. Without treatment, this phase can last up to 72 hours. The final phase is the postdrome, or the migraine recovery period. After the head pain resolves, many people experience lingering fatigue, brain fog, or mood shifts. Residual neck stiffness or sensitivity can persist for up to 48 hours, as this is a genuine part of the cycle. The underlying cause of migraine involves the Trigeminovascular system. When the trigeminal nerve is activated, it releases inflammatory peptides that cause brain blood vessels to dilate and inflame. This neurogenic inflammation sends signals to the brainstem, which we experience as intense, throbbing headache pain. Another key mechanism is cortical spreading depression. This is a slow wave of nerve cell activation and subsequent suppression that spreads across the brain surface. It is thought to be the biological basis for the aura phase and likely helps trigger the trigeminal pain pathways. A critical molecule in this process is CGRP, or calcitonin gene-related peptide. This molecule is released during an attack and acts as a potent dilator of blood vessels. Its discovery has been a breakthrough, leading to new medications specifically designed to block CGRP or its receptor. Migraine triggers can provoke an attack in those who have the disease. While triggers vary, identifying your own patterns is essential for prevention. Keeping a detailed headache diary is one of the most effective tools to uncover how diet, lifestyle, and environment contribute to your attacks. Food and drink are common triggers. Alcohol, especially red wine, is a well-known culprit. Changes in caffeine intake, either too much or sudden withdrawal, can also trigger attacks. Additionally, skipping meals, fasting, or consuming foods with tyramine and nitrates like aged cheese or processed meats can be problematic. Lifestyle and hormonal factors also play a major role. Poor sleep, high stress, strong sensory inputs, and weather changes are common lifestyle triggers. For many women, hormonal fluctuations during the menstrual cycle, use of oral contraceptives, pregnancy, or the transition into menopause can also influence migraine frequency. The clinical diagnosis of migraine is based on history rather than a single test. The ICHD-3 criteria suggests that having at least 5 attacks with specific features, including duration, pain quality, and associated symptoms like nausea or light sensitivity, supports a diagnosis when other causes are ruled out. Finally, migraines are divided into 2 main categories, those with aura and those without. Migraine without aura is the most common form, accounting for about 75% of cases. Migraine with aura affects 25% of patients, characterized by the presence of neurological warning symptoms before or during the headache. Chronic migraine is defined as having a headache on 15 or more days per month for over 3 months, with at least 8 of those days exhibiting migraine features. This condition often evolves gradually from episodic migraine and is strongly linked to the overuse of acute pain medication. There are several special migraine variants. Hemiplegic migraine is a rare form causing temporary weakness on one side of the body. Vestibular migraine involves prominent dizziness or vertigo, with or without head pain. Retinal migraine causes temporary vision loss in one eye, and menstrual migraines are linked to the cycle. Cluster headache is a rare but extremely severe pain condition, far more common in men than women. Attacks occur in clusters, with daily pain for weeks or months, followed by long periods of remission. Due to the intensity of the pain, it is sometimes called a, quote, suicide headache. Cluster headache symptoms include severe one-sided pain around or behind one eye, lasting 15 minutes to 3 hours. They can occur multiple times daily, often at night. Unlike migraine patients, those with cluster headaches often feel restless and agitated. Same-side tearing, nasal congestion, or a drooping eyelid are also common. While both are primary disorders, cluster headaches and migraines differ significantly in frequency, duration, and patient behavior. While migraineurs seek quiet and stillness to reduce their pain, cluster headache patients often find it impossible to sit still due to the extreme severity of the attack. Secondary headaches are symptoms caused by an underlying medical condition, such as infection, vascular events, trauma, or tumors. They account for a small minority of cases, but recognizing the red flags is vital for early detection, as treatment must target the underlying cause rather than just the pain. Dangerous secondary causes include subarachnoid hemorrhage, often felt as a, quote, thunderclap headache, and infections like meningitis. Other serious causes are stroke, brain tumors, giant cell arteritis in patients over 50, and idiopathic intracranial hypertension, which involves visual changes. Seek emergency care if you experience the worst headache of your life, a headache accompanied by fever, stiff neck, confusion, or weakness. Also, seek help for headaches following head trauma, those associated with seizures or loss of consciousness, or new headaches during pregnancy. A diagnostic workup begins with a thorough medical history. Your doctor will ask about the age of onset, the pattern of the pain, its location, quality, and duration. They will also inquire about associated symptoms, triggers, relieving factors, family history, and all medications you are currently taking. The physical examination for headaches includes checking vital signs like blood pressure and temperature, a comprehensive neurological exam to test strength and reflexes, an eye exam, and palpation of the scalp, neck, and arteries to check for tenderness or signs of meningeal irritation. Imaging is usually not required for patients with a stable, known pattern of primary headache and a normal neurological exam. However, it is strongly recommended if red flags are present, if there are new neurological findings, a sudden thunderclap onset, or a new headache pattern after age 50. Maintaining a headache diary is a high-value tool for management. By tracking the frequency, duration, and severity of attacks, alongside potential triggers, medication use, and treatment responses, you provide your doctor with the objective data needed to make informed decisions about your care. Treatment generally follows two paths: acute or abortive, therapy taken at the start of an attack to stop pain, and preventative or prophylactic, therapy taken regularly to reduce the frequency and severity of future attacks. These approaches are often used in combination. Acute treatment for mild attacks often includes NSAIDs like ibuprofen or naproxen. For moderate to severe attacks, triptans are standard. Early treatment at the first sign of symptoms is critical for effectiveness, but frequency must be managed to avoid the risk of medication overuse headache. Triptans work by targeting serotonin receptors to constrict dilated blood vessels around the brain and block the release of inflammatory neuropeptides like CGRP. By interrupting pain signaling in the trigeminal system, they can resolve an attack, though they are not suitable for patients with certain cardiovascular conditions.